We will call to order today's meeting for the Board of Health for March. Today, March 8th at 12 o'clock. And we will start on the agenda with roll call.
Jamie Steig,
Here.
Avish Nagpal, Arlette Preston,
Here.
Kayla Nelson,
Here.
Lynn Telford,
Here.
Neemal Day, Bernie Dardis,
Here.
Grant Severson, and Jim Capitan.
Okay. Thank you. Next on the agenda is approval of the minutes from November 17th and December 15th, 2023. Entertain a motion to approve.
I'll move to approve with amendments, however, so
Go ahead.
wherever there's the comment, motion to approve by Ms. Telford, I'd say remove all of those. It's confusing. And then just secondly, just an issue of spelling Brenda Derrick's name correctly. You can probably just correct her name wherever it is. Her last name is Derrig,
Okay.
not Derrick.
Okay, so we can make note to make those updates.
I will second with the amendments as noted by Commissioner Preston.
Thank you. Are there any opposed? Okay, hearing no opposal, motion carries. And minutes are approved. And next on the agenda is department updates.
Hi, everybody. Just wanted to update you a little bit on the director position. So that position has been formally posted as of March 1st. So the intent is for that to be posted for a month. And then they will have a selection committee. It will probably involve a couple of you and some other city people as well. And they will work through that process. So hopefully the intent is to have someone on board by that July 5th date. My date is a little flexible if that doesn't happen. And so the hope is to have kind of a warm handoff where I can spend some time with the incoming person before I officially leave. So otherwise, if you have any questions, let me know. Otherwise, that's kind of where we're at right now. I should have more of an update at the May meeting as well.
Sounds good.
Madam Chair, Desi, do you know the extent of the ads, where they're going?
We worked pretty hard to get them to, I mean, I think it's got a pretty good reach. I think it's been out for, since the first, and I think there's already a pretty good number of applicants coming in. So I think it is reaching where we need to. I know we have some farther Minnesota ones and things like that. So I think it went out through some public health channels, education facilities, different things like that, public health associations. So I'm feeling pretty good about the potential reach of it.
So regional.
Well, I think the intent is to be any national.
Okay. Thank you.
Okay, anything else for department updates? Okay, next up is Cass Clay Food System update.
Good afternoon. Thank you for having me. My name is Michelle Draxton. I'm a registered dietitian in the Health Promotion Division at Fargo-Cass Public Health. So I would also like to wish you all a happy Nutrition Month. I am here this afternoon to provide an update on some food systems work happening here in our community. But before I get to that, I do want to provide an update on the National Health Initiative, Food is Medicine. So we're going to start with some numbers. So at the national level, nearly 34 million people live in food insecure households, meaning that almost 34 million people do not have access to the foods that they need to live their fullest lives. In 2021, household food insecurity affected 12.5% of households with children. About half of all American adults have one or more preventable chronic diseases, which could include cardiovascular disease, type 2 diabetes, some cancers, high blood pressure, and many of those are related to poor diet intake and physical inactivity. Lower food security is associated with a higher likelihood of being diagnosed with one of these chronic diseases, and nearly $173 billion a year is spent on healthcare costs for obesity alone. And in the United States, over 40% of adults are living with obesity, so that's more than 2 in 5 adults. In September of 2022, the White House Conference on Hunger, Nutrition, and Health resurfaced a calling to end hunger and reduce prevalence of chronic disease in the United States by the year 2030. Federal investment into various settings of these topics increased, and those topics were put into 4 different pillars, and one of those pillars being integrate nutrition and health. In the fiscal year of 2023, the Omnibus Appropriations Bill gives $1.7 trillion for non-defense discretionary programs, so that would include healthcare and research, nutrition programs, and housing assistance, for example. So thanks to that appropriation, the Food is Medicine initiative was established by the United States Department of Health and Human Services, and that was really to propel the effort in nutrition to improve and sustain health. And then that led to the first ever Food is Medicine Summit. So that summit was held earlier this year in Washington, D.C., and again was hosted by the U.S. Department of Health and Human Services. You can see that there were a variety of panelists that were involved, and it also launched partnerships to really bridge the gap between the private and public sectors. And the main partnerships that were forged at that point were between Feeding America, Instacart, and the Rockefeller Center. So Feeding America, if you are not aware, is part of a nationwide network of food banks, food pantries, and community-based organizations in the United States that works to address hunger. Instacart, with its Instacart Health Initiative, is utilizing its technology, partnerships, research, and advocacy to really expand access to nutritious foods. And the Rockefeller Foundation is a leader in the movement to integrate food and nutrition into healthcare. So the purpose of the summit was to propel the Food is Medicine initiative, to contribute to the national focus on hunger, nutrition, and health, and also to support the transition from an illness care system to a wellness care system. So really emphasizing disease prevention and health promotion. So at the national level, there are some current Food is Medicine efforts underway. So the National Institute of Health is currently asking for more research on Food is Medicine, really to investigate the efficacy on interventions on nutrition security and investigate how food insecurity impacts various health outcomes. The Centers for Medicare and Medicaid Services, or CMS, is becoming more flexible in allowing states to implement Food is Medicine efforts. So for example, they are allowing organizations to qualify for advanced payments through Medicare to help implement these programs to try to tackle food insecurity. The Indian Health Service, they currently have a pilot program underway for produce prescriptions. And the Administration for Community Living, they have developed a public-facing resource with information to really support the design and implementation of Food is Medicine approaches. And so that is something that is available for review. So next steps when we kind of think about this Food is Medicine initiative, really want to try to think about how can we continue to learn and talk about this initiative, because we're really at this crossroads of health as a country, I mean, even as a globe. And so how can we really continue to have the conversations? Health.gov's Food is Medicine webpage will continually be updated with progress and as things move forward. So just want to bring your attention to that. Definitely want to encourage creating and carrying out conversations on what food is medicine should look like here in our community. And then also considering to explore funding opportunities to be able to implement some of these activities. So as mentioned on the previous slide, the NIH is asking for research on these initiatives. And they do have a notice of special interest out right now for funding, and that does expire close to the end of this year. And then CMS also has some pilot program opportunities to consider. So as we think about food as medicine and how it could potentially be incorporated into our community, it seems like a good fit and a transition to talk about our local food policy council, and that is the Cass Clay Food Partners. So the Cass Clay Food Partners has a mission to improve all levels of our community food system to assure that residents have access to safe, nutritious, affordable, and culturally based foods. We do have a website, cassclayfoodpartners.com, so all of that information is listed there as well. So a really brief overview of what a food system is. As you can tell with the diagram there on the right, it is big, it is complex, it is very interconnected, and there are so many moving parts. But it really does influence nutrition and food, public health, community development, ag, and so much more. And so it does include, the process of farm to fork, if you will, but it also is everything else in between and really includes the processes, policies, and all of those items that are needed to feed our community. So a brief history and timeline of the Cass Clay Food Partners. It was formed back in 2010, and at that time it was called the Cass Clay Food Systems Initiative. It was a joint effort between public health and extension on both sides of the river, so in both Cass and Clay counties. In 2013, the Metro Food Systems Plan was completed, and part of that plan came the recommendation to form a food policy council. So from that, then the Cass Clay Food Commission was formed. And the Food Commission consists of 7 jurisdictions, so both Cass and Clay counties, the cities of Moorhead and Dilworth, as well as Fargo, West Fargo, and Horace. And the purpose of that Food Commission is to address and discuss policies related to food systems. There was a reorganization back in 2017, which also changed the structure of the Food Partners, which we'll talk about, but they also received a new name, which is the Cass Clay Food Partners. After that reorganization, Food of the North started, and they unfortunately did dissolve back in 2023, but we can touch on that in a little bit as well. So this is an overview of the structure of the Cass Clay Food Partners. So as you can see, it has 3 arms: the Cass Clay Food Commission, the Steering Committee, and the Action Network. So the Food Commission, again, the purpose there is listed at the top. There are voting members, and they are listed there in terms of all of the jurisdictions. And the commission is also made up of 5 at-large members, and each at-large member serves a term for 2 years. So the steering committee currently consists of 10 individuals, and the steering committee is an advisory committee comprised of key government organizations and food system experts that work to provide direction, organization, and management to the Food Commission as well as the Action Network. So Food of the North, as I mentioned, really was that Action Network arm of the Cass Clay Food Partners. Since 2018, they would host events on the first Fridays of every month, hence the name First Fridays. And it was a time to really bring community members together to educate on a specific food-related or food system-related topic, have good conversation, and just engage with members of the community. And ideally, the goal was to have people get energized and then take action on the topic that was presented at First Fridays. And as mentioned, they did dissolve in 2023. And so the steering committee is really at an instrumental point in terms of moving forward as what that Action Network arm looks like, and have definitely been having some conversations about where to go with that arm. So to highlight some of the commission work over the years, early on, the focus was really around urban ag, which kind of makes sense given the area that we live in, food access and sustainability. The Food Commission also has been incredibly instrumental in writing and developing blueprints, issue briefs, and snapshots. So there are about 18 of these documents, and they are policy related, and they have been driven by interest and input from members of our community. And they all include research about the specific topic, an assessment of how that issue is or is not being addressed within each jurisdiction, and then it also provides examples of how other communities are addressing these issues. Food system language has also been included into several comp plans around our area. And several of the topics that have been covered in the blueprints have been moved forward throughout the community. So in several cases actually been established as ordinances throughout the community. So examples of that are backyard chickens, a gleaning network, healthy corner store initiatives, as well as boulevard gardening. The Cass Clay Food Partners also had a very strong presence during the COVID-19 response. They were able to develop a community food resource list that was continuously updated as we learned more about our food system and also how our food products were being delivered and distributed. They held 45 Facebook Live events really to discuss, again, food specific and food system specific topics. They updated several guides about codes related to food systems. And from all of the work that was put into this food response, there was an article published back in 2021. So our current work, so this month at our Food Commission meeting, we are going to be talking a lot about school meals. So as you may know, there's a strong difference between the states of North Dakota and Minnesota as it relates to universal free meals. So we will be talking about that as well as the meal repack program. We also talk about food insecurity, the social determinants of health, and civic engagement in food systems. The food partners were also selected to participate in a national community of practice with 10 other food policy councils from around the nation. And as you can see, it's led by Ohio State University, Johns Hopkins University, and the USDA, with the hope to really understand how different food policy councils from around the nation operate and function to be able to develop a framework then to be disseminated with those findings. We are also starting the beginning process of a strategic plan with the Cass Clay Food Partners. Again, as mentioned, that Action Arm network is kind of in flux, and so we want to be really mindful as to how that looks moving forward. But in addition to the Action Network, it just feels like a really good time for our group to think about what the next steps are, what our objectives are, so we are a cohesive group moving forward to really meet and serve the community. A couple of years ago, we were able to partner with the City of Fargo comms team to be able to develop some educational and informational videos around the food partners. Sometimes the term food system can be confusing or overwhelming, and so we really wanted to try to find a concise way to be able to share information about the work of the food partners with the community. So you can see the topics of the 5 videos that are listed there. They're also on the website, cassclayfoodpartners.com. If you are interested in checking those out, they're all about 2 minutes in length. I would also invite you to join our next Food Commission meeting, which is next Wednesday, March 13th. We meet at 10:30 until noon right here in the Commission chambers. With that, I thank you for your time this afternoon. I am happy to answer any questions you may have.
Go ahead. It's just flashing.
Yeah, it's flashing.
Mine's okay.
Can you hear me anyway?
Here.
Yeah.
Let's try this one.
How are we defining food insecurity? Looks like when in your initial slide, it's affecting 10% of our population. So is it based on an income level, or is it more inclusive, including access to food and other things, other barriers?
Right. So it has more to do with being able to adequately get the food that you need to live like a fulfilling life. It doesn't have to, or it's not defined by income.
The prescription for produce is a brilliant idea. Can you remind me, is that, who's doing that? The produce prescription? IHS?
Yes, IHS.
Okay.
So in 2023, they did allocate about $2.5 million to 5 different tribal groups to be able to trial or pilot that produce prescription program.
That's just the cost of groceries. You know, it's hard for anyone, let alone people that have access issues or financial barriers. So that's a fantastic idea. I hope to see that spread to other carriers. Any other questions? Yes?
Michelle, have you been able to get a sense of whether any granting programs will come out of this, or?
So there are a couple grant opportunities available in terms of really being able to contribute to that research part. But it will be interesting to see if, because of what is learned from this research regarding food as medicine, if then funding will be allocated to be able to implement some of these things more nationwide.
Okay.
How are you able to identify those people that are food insecure?
That is a really good question. So people who identify as food insecure likely will visit food banks and food pantries. Many times they might also receive SNAP benefits, participate in WIC programs, really the programs that do help supplement the financial burden to be able to purchase foods.
I understand the WIC program, but at food banks, there's never any data collected as to individuals' names or addresses or anything like that. So how do we continue to keep them on the rolls?
So Feeding America is really the national group to, collect some of that data. If you do go to the emergency food pantry, for example, you do need to provide some information so they are able to keep track, as well as household size and things like that. So there is data that is collected.
Thank you.
I know there has been some push in the healthcare arena to screen. So on a rooming form asking if some food insecurity questions, and I think that's been a good way to help capture some of that as well.
Yes, so that's called the Hunger Vital Signs. And so those are 2 screening questions that are asked. And it's my understanding that those are starting to expand in terms of the areas where they are being asked. So Fargo-Cass Public Health, for example, their clinic also does screen for those questions. Yes, thank you.
I imagine that they will be a regular screening question in healthcare systems, similar to some of the other ones, but I was going to ask if Fargo-Cass Public Health Clinic is doing those screenings, so.
Yeah, I was just going to share that at Sanford Health, we, at every well child visit for families, it's actually a 3-question questionnaire. And if they answer yes to any of the 3, they qualify. And we do track that data, and I believe it's submitted to the city, I would assume, but it is tracked on a regular basis, at least within our healthcare system.
I was wondering, when we do the community needs assessment, if there's a way to pull data on food insecurity from the health systems that are screening, that could help inform the prevalence maybe of the usage. And at Sanford, they not only do the screening, they also have the food pantry, which is amazing. So families can go right downstairs and get things that they need for their family. So maybe something to consider in the future for the community needs assessment. And how do we get that data from our private healthcare systems too?
Thank you.
Great conversation. Thank you very much. Okay, next on our agenda is the Ending Homelessness Together event recap.
Hi, thank you so much for letting us be here this afternoon to recap our Ending Homelessness events that were just last month. My name is Chandler Esslinger, and I am the Community Liaison for Fargo-Cass Public Health in the Harm Reduction Division. I'm based out of the Engagement Center. I have a few slides that I'll present, and then we also have one of our community partners who is actually implementing some of the strategies that we learned about at this event. But before I do that, If we condense the 6 hours of events that we had last month into a less than 5-minute video, the comms team put that together for us, so we'll air that first.
So I'm going to talk a little bit about what Housing First is and what it isn't. Where it used to be individuals would be on the street, and the goal would be to try to get them in shelter. And once they were in shelter and stable, they go to transitional housing. And once they went to transitional, if they met all the rules and qualifications and did the right things, then they would be offered permanent housing. So that is the way most systems work, and it's the way ours worked up until 2014. So the idea with Housing First is we should be skipping all that. So if an individual is unsheltered or in a shelter or in transitional housing, they're still homeless. So if the goal is reducing homelessness, the true Housing First programs that work the best, we're going to take individuals directly off the street and permanently have them exit homelessness directly into permanent housing and skip everything in between. And when we talk about Housing First, it is not housing only. This is housing with intense supportive services to make sure that individuals maintain their housing. So a couple of key principles. Again, this is immediate access to housing, and this is housing without preconditions. So individuals that are homeless, regardless if they're having mental health acuity issues, addiction issues, employment issues, whatever that is, everybody deserves the dignity of housing. And the way I like to explain this to you all, you can imagine if you have medical issues or income issues or employment issues, addiction issues, and we're going to ask you to focus on all that while you're sleeping under the bridge in a tent. None of us are able to do that. You need the foundation and the safety of permanent housing to take a breath, feel safe, and then focus on all these things. Again, our case management is voluntary, and our clients determine what that means to them. Case management does not mean the same thing to you or me. An individual should choose what that treatment is for them. Fargo has seen an increase in homelessness just like we have, just like every single city in America has. If you look at numbers in 2023, it's going up everywhere. So a couple other data points, 0 chronically homeless individuals unsheltered for the past 2 years, 97% housing retention rate. And that is what speaks to the true fidelity of Housing First. You have to do it the right way.
I really want to talk a little bit more about why starting with chronic homelessness. So I'll give this to James and Jan. James, maybe talk a little bit about why Milwaukee started with chronic homelessness specifically, and then Jan, we can talk a little bit about why that matters for our community.
Sure. So again, for individuals that are chronically homeless, that's going to mean individuals who have been homeless the longest, and most likely individuals that are dealing with a lot of trauma, acute mental health issues, addiction issues. So for us as housing and homelessness providers with our mission, that's naturally what we're going to focus on. But even from a community perspective and even a taxpayer perspective, this was a population that was using an awful lot of emergency services, going in and out of the criminal justice system when they really didn't need to be there, going to emergency rooms for basic care issues. We were able to demonstrate a very significant cost increase for taxpayers and local taxpayers by focusing on that population, getting them into housing.
The one thing that I really want people to think about is how vulnerable the population is. Those folks that meet that definition of chronic homelessness have been unsheltered often for long periods of time. They're facing all of the different health complications that come with homelessness, and they're most likely to die outside. And we know it costs far too much to do nothing, and James has spoken about that so well. But it also, there's this human toll, right, that comes with it. And I just don't believe that this community is okay with that. I don't believe that this community is okay with having some of our neighbors just live outside and exist outside.
All right. While we're getting my slides pulled up here, I just wanted to call out the level of collaboration that happened with our communications department in order to plan, cover this event with multiple different types of media, and then package all of that information in a way that we can easily share with the public. And we are just so grateful for their partnership and their continued partnership as we continue the momentum from this event and continue to tell the story of where we go from here. So we had a total of 3 different events back in February about ending homelessness. The morning event was an invitation-only event at Fargo-Cass Public Health, where we had a variety of different leaders representing multiple jurisdictions in our cross-border in our community, different sectors, and all different levels of government. And that was really an opportunity for folks to get a crash course in housing first. And ask some of those questions that they have, maybe some of the hesitancies they have around the Housing First approach, in kind of an environment with other leaders where they could all learn together. The afternoon, we had a public event here in City Commission chambers where we had James talk a little bit more in depth about the Housing First approach, the nuts and bolts of all the different components that looks like in Milwaukee, and then also answered a lot of public questions. People were really curious to know how to implement this and really just understand how can we square what Milwaukee had success with what we're seeing here in our community. And then in the evening, we had the great fortune of having a short documentary screening and panel discussion with area leaders at the Fargo Theater. We were really proud to have our message of ending homelessness together on the marquee outside of the Fargo Theater. And so that was a really engaging event. Lots of great questions from the audience at that event as well. And as the video mentioned, you can go back and watch all of those events on our YouTube page as well. I really loved one of most of the photos that we got from this event, and it's not an exaggeration that hundreds of people attended the events that we had last month. And one of the comments that James had made while he was here, that he has never seen a community's public support for ending homelessness like this. And so I just really wanted to highlight that. I'm so impressed with our community and the engagement in these events and our commitment to doing something different moving forward. So James, for those of you who weren't able to attend any of the events, he is the Milwaukee County Housing Administrator, and he's the author of Milwaukee County's Plan to End Chronic Homelessness, which ultimately led to a 45% overall reduction in homelessness since 2015. And Milwaukee remains on pace to be the largest county in the nation to end chronic homelessness. And that's also where we really see the biggest benefit in our community, starting with ending homelessness, is beginning with that chronically homeless population. So what James really shared with us was what was Milwaukee's recipe for success and what would it take to implement those things in our community. And really it's rooted in that housing first orientation. He highlighted the need to subsidize housing. People need support in making their rent payments. And so that's a really important factor. We need to continue to invest in supportive housing developments. Some of our chronically homeless folks have complex needs, and so it's really important that we design systems that support those complex needs. Case management services need to be housing first oriented and flexible, and they actually have a case management system within their county, and we'll be highlighting kind of similar components that we have in our community with our nonprofit partners. Outreach and commensurate staffing has been incredibly important. Outreach plays a really important role in understanding just how many people in our community are experiencing homelessness. We need to work collaboratively with all of our partners to ensure that we're getting the complete picture. And then coordinating all of the resources that are available in our community and making that joint commitment to housing first. We just recently had a meeting with all of the shelters in the area, and one of the things we talked about is that although we may have different philosophies in our programming, we can all pull in the same direction. And so how do we make sure that we're coordinating those resources and philosophies so that we are pulling in the same direction? So I just wanted to explore again the difference between what we might consider a traditional housing model and a housing first model. This is what we see in our community in a lot of the service providers that we have, and it does work for some people, but it doesn't work for all people. And so we have to figure out how can we meet the needs of our entire community, not just the people who are most well suited to benefit from the model that we currently have. So like James mentioned and like the video shared, most of the time you kind of have to earn your way out of shelter into housing. You have to address your medical issues you may have, any mental or behavioral health issues you may have, and after those issues are resolved, then you get a trial period where you get to transition into one form of housing, but you're still considered homeless when you're in transitional housing. And then once you're successful in that environment, then maybe you can get a voucher. Maybe you can get the support you need to move out of that into a permanent location. But there's lots of opportunities to kind of fail if you have to pass all of these different pieces in order to get housing. And so what Housing First really has us think about is how do you bypass all of those steps, get somebody the stability they need to address all of those factors, and ultimately that leads to more stability and higher rates of success. So really thinking about how housing ends homelessness, and then we can address all of those different issues. Again, our video shared these same statistics, but I just wanted to highlight the immense success that Milwaukee has had with their Housing First approach, a 92% reduction in unsheltered street homelessness within the first 5 years. That's an incredible statistic. You don't see statistics like that in communities that aren't implementing Housing First. And like James mentioned, although all communities across the nation have seen an increase in homelessness recently, when you have a system that is well situated to respond to that increase, then you're able to be more effective in resolving that crisis, right? Another big component is just the immense amount of cost savings that come with Housing First. People who are chronically homeless live in a state of crisis. A lot of times they are being transported to the hospital. There are lots of jail or detox stays, staying in shelters. All of those things cost our community money. And so when we can move somebody effectively into permanent housing and give them the supports they need to be stable, it decreases the utilization of all of those types of services, which saves our community money. And actually our local community partner will talk about some of the cost savings we're already seeing with the Housing First approach here in our community. So James has a number of things that he shared that would make us successful in our community. And actually, one of the first next steps we're taking is getting kind of a formal recommendation from him about his observations of our community and what we really need to focus on implementing within the first 30, 60, 90 days since his event. But that really hinges on all of us committing to a shared approach and vision around Housing First and starting with ending chronic homelessness. That will really free up a lot of the resources in our homelessness response system to do what it's always been intended to do. So that's a really, really crucial component. We need that variety of public and private partners. We had a diversity of people attend these events, and that's because it takes a diversity in commitment to this issue to end homelessness. Again, housing subsidy is incredibly important. People need support in being able to afford a place to live. So that's something we need to consider. We also need to recognize the role that local investments play in solving this issue. HUD funding alone is going to be insufficient to address this crisis. So if this status quo is currently costing our community a lot of money, how do we use that money in a different way to actually resolve this issue? We need flexible case management services, which again, we do have components of that already in our community. We need people to be able to adapt to the specific and unique needs of an individual who's experiencing homelessness and all of the complexities that may come with their situation. Again, additional supportive housing developments. Some people need support for their lifetime. Some people have complex issues that require that level of investment and support. And so how do we ensure that we have the right level of care available in our community for the people who need that? Coordinated outreach and quality of data, again, is incredibly important. How can you demonstrate that you're making progress on an issue if you don't have quality data to back that up? And how can we make sure that, again, our whole community is really pulling in the same direction? Public education, Again, a really important component of not only getting buy-in from individuals about how the Housing First approach works and why it's successful, but also in demonstrating the success that we are having as we continue to move forward. That's why we had all of these public events when James was here, and that's why we're going to continue the conversation moving forward. One thing that James also mentioned is that communities that he's seen who've attempted to do this but have not been successful have not had one person kind of coordinating all of the different pieces because it requires a lot of collaboration. And so it's important for us to consider what a point person looks like for implementation and accountability in ending chronic homelessness. This is a photo of our panel discussion at the Fargo Theater, and I moderated the panel, which was a great privilege and honor among some of my most esteemed colleagues. On my right there, we have Sarah Kennedy, and she is the program director for Presentation Partners in Housing's prevention and navigation team. So we really wanted to talk about the role that decreasing the inflow into homelessness plays in ending homelessness altogether. But Presentation Partners in Housing serves people along the continuum of experiencing homelessness. So people who are at risk of homelessness and people who have been chronically homeless. So that's why we invited today Beth Olson, the Housing Navigation Program Director for Presentation Partners in Housing, to talk about their Housing First Housing Navigation team and the success that we're seeing with that model already in our community. So I'll welcome Beth up here.
Thank you. Thank you guys so much for having me here today. I'm excited to just kind of take a quick break from the homelessness ending that we're doing and talk shop. So thanks for that opportunity. Yes, like Chandler said, I'm the Housing Navigation Program Director located at Presentation Partners in Housing. We started this Housing Navigation Program in 2016. And so I would encourage you to kind of like my Golden Girls love of my life, Golden Girls, picture it. 2015, we had just implemented coordinated entry in our homeless response system. And for the first time, we were getting some pretty good data, not only on the number of people who were homeless, but what those people who were homeless needed to end their homelessness. We had an assessment that we did that kind of measured who is most likely to die on the street based on their homelessness and the acuity of services that they had. And we found overwhelming numbers of people in Fargo-Moorhead. We were able to identify, some people had been sleeping every night at the Gladys Ray shelter since it opened 7-8 years before that. We had some people who had been staying in the whole shelter system since the 90s, who had never been housed. And we also were able to identify, to a certain extent, a population of people who were living outside that weren't even staying in our shelter system because their needs, their acuity was just too high. And Housing Navigation came about as incredible visionaries, the United Way of Cass Clay, had put out an income stability initiative and a grant. And a lot of us agencies, I say us, maybe it's we, but a lot of the agencies in our area had reached out. We wanted case management dollars to help the people we were serving get into housing. I had been working at the Dorothy Day House in Moorhead for about 6 years at that time. And of all of those people that we were serving, what we noticed was, you could try to get somebody into housing and it was a ton of work and we would get them into housing, but you couldn't help but see year after year, over and over again, a landlord would call you. You had moved someone in 2 months before that and they said, yeah, it was going great, but all of these things are happening. They haven't taken out their garbage for the whole time they've lived there. They're mean to their neighbor. People think they're weird. It's not working. And we saw that over and over and over again. And so we wanted to take the opportunity to flip that system on its head. So we had convened a design team of people already in the homeless service response system to put together a model to do something different and to do something with fidelity to Housing First. And that is where our housing navigation program came from. So it landed at Presentation Partners in Housing. And what we wanted to do was take away a lot of the, I liked what James Matthey noted about HUD funding can't fully end homelessness, a lot of which, because it wasn't designed to, HUD funding wasn't designed to end homelessness, but it can help. It's about collaboration. But what we wanted to do was just go on this housing first, evidence-based momentum. Like, if we just do housing first based on fidelity to the model, if we add in collaboration with existing community resources and partners, and we really take a look at the data, how can we most effectively serve the hardest to house folks? The people in our community who, like I said, had been staying at shelters for years and years, or had been staying outside, or what we had found, they had been housed a couple of times, but it didn't work out, and they weren't supported. So housing navigation, our key program component, was that we wanted to target people with the highest vulnerability. They had been homeless the longest for the most issues, kind of like what James Matthey was just here talking about. We wanted to consider more barriers to housing as being more worthy of housing, more needing of housing, more houseable. So historically, you would look at somebody who had been homeless, a family we worked with, they had been homeless for a year and a half. They had kids, I think she had like a 6-month-old. So that 6-month-old had been living either in a shelter, in a car, or in a really not great place on a couch for their entire life. And when we looked, said, oh, they've actually been housed, they have 3 evictions on their record. Well, but what we know from the data is that this family, the mom was African American, and we know from the data that African American women experience evictions at such a higher rate, a hugely higher rate than just a white woman. And so instead of saying like, oh, well, that must mean that they aren't a good fit for housing, we said, oh, that must mean that their homelessness is caused by equity issues, and in order to end their homelessness, we have to fix that equity issue as much as we can. So they need to be housed, and they need to be supported in that housing. And what we really wanted to do was, instead of all this red tape, all the colors of tape that there could be, to get people into housing, we want to say, stop that. Instead of it being about like who's worthy of housing, could it be about, we have to house people because their lives depend on it. And as a system, how do you systemically put it together so that you can house people like their lives depend on it? And why should you do that? Because their lives do depend on it. At least 20 people experiencing homelessness die every single day in America. They die in the cars, tents, shelters, on the streets. Literally almost all of these deaths are preventable. And to even speak to the nature of that, we don't even have the best data. That's not a big data point that our homeless systems have even covered, is how many people are dying. And if you look at our medical system anywhere, that wouldn't be a data point that would ever be ignored. But that is just not even something we've been tracking. So the National Healthcare for Homeless Council estimates it could actually, if we had the correct data, be more like 48 to 127 people dying every day due to homelessness. So how do we turn that on its head? So the key program components, without talking for 8 hours, because I would prefer to talk to you for 8 hours about it, but I would never do that to you. So we're gonna condense this down and have questions after. But key program components are that the work truly starts once people are housed. We gotta reverse that traditional model where I was working in the shelter, I would spend hundreds of hours helping people get into housing and then be like, call me if you need something, God bless. Like, gotta house the next person who could die on the street, which is in many ways a normal model, right? But it doesn't work for chronically homeless individuals. and they fall out of housing and they're more heartbroken, traumatized, and sick than ever. So we turn that on its head. You take as much time as you need to house people, but hopefully it's as quick as possible. And then if you think about it, takes about 10% of your energy to house them, then it takes the rest of the 90% to keep them housed. Really like 900% for some people who have never been housed before. So we have our intensive case management model. Housing navigation, small, oh no. Did I do that? Okay. Oh no, can I go back? Spoilers, stop. Okay. Small caseloads, 10 to 12 per worker. Most of our visits, 98% of them occur way outside of our offices. You need to meet with people in their homes in order to teach them how to live in a home. A lot of teaching and hands-on support and referring and connecting for those additional supports. It's housing people, supporting people, and never giving up. We also can't end homelessness without landlords. Landlords are probably in many ways our most essential partner. And sometimes it breaks my heart when I hear things talked about landlords almost being like the enemy, when in actuality, housing navigation, we've had success. We've been able to house like 98% of the people who've ever come through housing navigation with landlords just in the community. We have some incredible landlords who would give the shirt off of their back to help our people be successful. It is a smaller percentage, but they're so important, and they are the magic. And it's how we end homelessness in partnership. So secret sauce, strong partnerships with our landlords. We've done some master leasing. We've worked with some places with on-site supports. Mostly it's been scattered site, which if you look at Housing First programs across the country, it's really like 80% of people want just the plain old scattered site, and a lot of landlord incentives. We also partnered to provide the affordable housing of housing navigation with our wonderful partners at Clay County Housing and Fargo Housing to ensure that the people that we moved in had a way to afford their rent. And we're currently located at the Downtown Engagement Center. When we found out that was opening, we begged for one of the first locations there, because we were like, oh my gosh, our partners are there. This is how we're ending homelessness, one person and family at a time, is talking with Homeless Health Services, working with the Harm Reduction Division, working with incredible partners. So if you need us, we're right over there. And so I'm about to present you guys some data that we had gotten from housing people in our community who were some of the most vulnerable, most likely to die on the street. Here is some quick data on what that makes up. So of all the people we served in 2023, 100% were long-term homeless. That means they've been homeless for at least a year or 4 times in a 3-year period. 86% were chronically homeless, which means basically the same thing as long-term, except they have a disabling condition. And 100% of the households that we serve have a disabling condition of some sort. 80% have mental health issues. 82% have addiction issues. We have 3 out of 4 who have chronic health conditions. 23% were born with developmental conditions, and 86% of people have 2 or more co-occurring disabilities of the people that we're serving. We also have 73% who've experienced domestic violence either recently or as a child, and 72% of the people in our program are BIPOC. So housing first, because the cost of doing nothing is too high fiscally and morally. And we wanted to prove that. There's even programs across the country that we've looked and we've seen, what do they estimate that they save by housing and supporting some of the most chronically homeless people in their communities. And some of us at PPIH are really into specifics and data. So we wanted to get the most specific possible study that we could. So what we do is we got releases of information for everybody in the program who wanted to opt in. We had 30 participants opt in, and we send them to the hospitals, we send them to ambulance, we send them to detox. we send to jail. We get our partner agencies on the right who have provided us with this data to analyze. And what we do is we figure out for a year before they got into housing with our program, how many times did they go to the ER? How many times did they use those emergency services? And then we track very carefully how many times they use those after our program. And we were able to get an average of 1 year pre and 1 year post. What we learned is that 1 year in housing supported with us compared to 1 year on the street, for all those people, we were able to decrease their ER visits by 64%. We just cut it way more than in half. Ambulance rides, we were able to decrease by 66%. Jail stays, we decreased by 86%. And Captain Andrew Frobing and I have talked about it. A lot of the crimes, reasons people were in jail after housing were things that happened on the street. And when I say on the street, I also mean like when they were just trying to survive. And then when they're housed, they're easier to find, so then they went to jail. Not great, but we're working on that. But still, 86% decrease, simply by housing and supporting people instead of just leaving them to be homeless and possibly die. Detox stays at Fargo Detox, Clay County, and Cass County Jail decreased 90%. 90%. And shelter usage, 99%. Basically, if these were the only people in our community who were homeless, or if we were able to expand it, we could empty out our shelters. I used to work in a shelter. I ran a shelter. I can't imagine if 99% of the people we worked with suddenly were needed. So our grand total of savings for just those 30 people was just under $620,000. And if you look at where, those individually break down, that's $70,000 saved from jail, over $100,000 for ambulance, detox, over $200,000 just in ER visits alone. So not only does it morally feel like the right thing to do to ensure that our neighbors aren't dying on the street, it also makes sense cost-wise. And we wouldn't be here without our most important teachers. This is a small representation of the over 100 people that we've served in housing navigation since our inception, but they are truly the people who taught us how to implement it, who taught us what worked, who told us what didn't, who are the reason that we have seen that success and the privilege of doing this work. And that wasn't 8 hours, so I'm excited. Do you have any questions for me or Chandler?
I would start out by saying 2 former ER nurses here.
Woo!
Can
My mom as well, so this is fabulous.
So we can validate the importance of that decrease in the ER time, but then I think what would be kind of impossible but cool to see is just the downstream effects of the other savings, right? The time that people are not waiting in the ER with true emergencies, the time that people aren't waiting for an ambulance, the time that PD can be out on the street helping people in other ways. So I think the downstream effects of that not only houses people who need it, but puts our community in a better place from a response perspective. And so I just had to comment on that because I know the ER stuff sticks out to me, but.
Cool.
I just loved it. And I'm so grateful for all the work that you guys do.
Thank you.
Awesome. I think in my current role, I think I'm seeing mostly people struggling to keep their housing. I'm medical director at Share House. And so people having a return to use and then having to come in for treatment and then have to stop working and then sometimes give up their housing and then have to start all over. And that's where I'm seeing the big barrier. But I know that there's a lot more to it. So.
Yeah, absolutely.
But an important piece, how do we help people maintain their housing while they're not able to work, while they're getting treatment?
Yeah. It's been hard. I have a current case where it's a big struggle for the family because the dad's in treatment and they're basically forcing eviction or facing eviction here soon. And we're reaching out and trying to get them the help that they need. But yeah.
Are they Minnesota residents?
North Dakota.
Shoot, Minnesota has a really cool program where if they're in treatment, they'll pay all their rent and utilities.
So
We need
Opportunity
that.
for advocacy in
Yeah,
North
we need
Dakota.
that.
yeah,
Works really
so
good.
I think he's not doing well in his recovery journey because all he does is think about his wife and kids
Yeah.
being evicted. And then, yeah.
And I think it goes into, one of the big pieces with successfully implementing Housing First, like we talked about, is that support services. And one of the reasons, that when I talk about housing navigation, we say evidence-based practices, parentheses, Housing First, is ensuring that the people, providing the supports to people in housing, our team, I really consider them like Navy SEAL type specialists of homelessness and housing, because it truly is a different skill set. We haven't been able, previously we've treated homelessness with a disease-based model. And we thought that, but by, just getting them good and fixed, treating all that mental illness and all that substance use, people will be housed no problem. But what we know is that, like 44 million Americans live with mental illness in each year, and about half of a million people will experience homelessness. So it's more than that. And it's more than just having that mental health support or addiction support. It's really about having somebody who can hold all the pieces together, who can ensure, okay, mom and dad, kids, they're housed, dad needs recovery support. Let's make sure that we have that recovery support here. So he doesn't have to spend all of his time in treatment, and he could be focusing those skills that he's learning. He could do that right here at home where it would make sense and where he can still, feel safe with his family. So huge.
Thank you so much, Beth, for your presentation. It really brings home the fact that tying it back to James Matthey's visit, I was fortunate enough to make all 4 events. There was a 4th one that included the business community, and walked away from that entire span of events, understanding that, we need a data baseline, which I think it sounds to me like we're really close to having that and just bringing it together. The second being housing inventory, which you've already been doing some master leasing, which I did not even realize. And then thirdly, the case management piece, which it sounds like you got that down as a Navy SEAL, if you want to use that analogy. So we've got some major pieces in place, and he really emphasized that when he was here, that we have a lot of the big pieces of the infrastructure basically in place for at least attacking the shorter term, ending the chronic unsheltered homelessness individuals. Back to the comment earlier about evictions, one of the other things he talked about was stopping the bleeding, which that's the eviction piece, and having a longer term kind of strategy to working on that issue. But, from the event with the business community, I think, I don't want to speak for them, but what I heard was a strong commitment to working on this chronic unsheltered homelessness issue, and that they're willing to come to the table. And that's one thing James talked about a lot, was having the business community support and involvement, engagement. So, we're halfway there. So,
Yeah, I think
and
it's about,
it's wonderful to hear your part.
yes, no, thank you. I think it's about scale. When I was talking to James Matthey before his day of presenting, he said, "And do you do master leasing?" I said, "Oh yeah, we did that. We have a few." He said, "Oh, well, that's not enough." I'm like, "Yes, I know." We have a handful. We're able to afford with our current budget to have a handful. He said, "Oh, well, you need a lot more than that." So
Yeah, and not to negate that going into this, we're gonna have to put resources, more resources into what you're currently doing. So I think that's on us as a public, the business community, to come to the table with that, so.
Hopefully it's a reallocation and we spend, and it's not about just pouring more money in, it's
Okay.
about all the money that we will be able to see that we're really saving.
I just want to comment that I'm not surprised about the engagement from our community. And I think it validates Jan's perspective that our community does not want to see their neighbors outside.
No,
Makes me proud to be a part of the community and a reminder of why I stay here even though I don't like winter. It's the people.
worst.
So,
Winter's the
good
worst, people
reminder.
are the best, yeah.
Yeah. Anyone else?
So Mayor Dardis, I'd be interested, I don't want to put you on the spot, but you were at the elected official meeting. What were your thoughts?
Well, I didn't attend all four. I attended two of the different sessions. And I found it very, very interesting, particularly the way that they navigated in Milwaukee. To your latest point that you were just making, Commissioner Preston, is bringing in the business community. You know, about a year ago, when we were having a homelessness discussion, sitting back and listening to all of the issues and all the good things that we're trying to do, to me, it became very apparent that it was a matter of economics, that the business community, if they're going to have this type of housing, what type of vouchers are going to follow those, or how is some of that rent going to be subsidized? And of course, that could be by both state and federal levels of programs and the like. So I think that this gentleman is absolutely a master at what he's accomplished in Milwaukee because, you know, when he talked about the numbers of people that were in there, and one of the questions that he answered for me, which was surprising, I have to admit, I was surprising, is I said, what is the term that they are allowed to be in this housing? How long can they be there? And his answer really did surprise me, indefinitely. This is housing, permanent housing. And so that, I believe, really speaks to the significance of what they brought together because of vouchers or state and federal and local funding is how they did it. I never would have imagined that when you're looking for housing for the homeless, that it would be permanent housing. That was something I was extremely naive about. That wasn't in what I was thinking of. That is that there was a transitional part and helping them. And I get that. I have to tell a story about, you know, some of the things that you've navigated. I had the pleasure of serving on the Sanford Foundation Board for 7 years, and a number of those years I was chairman of the board. And I'll never forget, one of the nurses came to us that was volunteering over in Moorhead at the homeless shelters. And Sanford had been monitoring and collecting data on the expense of emergency services of these folks. And the request from this wonderfully dedicated nurse was that we would fund a part-time nurse at the shelter. And we did that. And we tracked the data. And in the first year, there was over $1 million of savings to Sanford because of the emergency services that they were dealing with. So these programs, these initiatives that we're working on are critically important for our community and for this homeless population. There's no question. And there is a financial possibilities that we're spending a lot of money that we don't need to be spending. And, not that we want to cut back their care or anything like that. So I'm looking forward to it. I know that we're looking at bringing the gentleman back in a couple of weeks. And I'm trying to clear my schedule so I can participate in that again. Thank you.
Great conversation. Any
you
other
guys so
questions?
much.
I'll just validate what everybody said. We work regularly with underprivileged people and population, and there's a lot of barriers we have overcome. We can deliver medicines to home. We can get medicines covered. We can have EMTs go to their home and get them the medicine. Make sure that we are doing directly observed therapies. There are medications which can be given once a month or once every other month as an injection, and we can go to their homes and get it. We can do telemedicine. The one barrier we have not been able to break down is homelessness. You can't do any of this if a person is homeless.
And perhaps next meeting, we can have our, the company Vans, they're making clinics on wheels right here in West Fargo, and they've made these vans for Portland, Oregon, that go to where, until these people have permanent housing, going to where they are and being able to do basic health care, dental care, where they are, in a driveway, in a parking lot, anywhere. So I think that's another, bringing the services to people in the meantime is something we can talk about maybe next time. Okay, thank you so much.
Thank you guys.
And
so
thanks for the
much.
work that you guys do. Next up is Health Officer Update.
Good afternoon, Board of Health members, and happy International Women's Day today. I was really happy we got to touch on other tenets of public health like homelessness and our food systems, because my report is essentially going to be an infectious disease update. Unfortunately, that's where I've been spending a lot of my time and focus. So I just wanted to update you on a few of those aspects of public health today. First and foremost, our pertussis outbreak that we are experiencing in the community, unfortunately, is marching on. Since October, we have now seen 39 cases in Cass County. One of those was technically what we call a border case. It was in Trail County, but it's in a school that we cover in Cass County. And these numbers are increasing. Since February 1st, we've had 19 of those cases. We've been averaging about a case a week over this past week, which is just far more than we are used to. You can see it typically for an entire year in Cass County, we average 5 to 8 pertussis cases. So just really relying and hoping our community will take precautions to halt disease spread. Please listen to the advice and recommendations that are given to you by public health if you're an exposure or if you are a case. If you're experiencing symptoms in any way, prolonged cough or other prolonged symptoms, we're really encouraging people to be seen by their provider to potentially have testing and or antibiotic treatment. Sometimes prophylactic antibiotics are indicated if you're a household contact or in other situations. So if you are concerned at all, we really encourage you to be seen. And then any suspected or confirmed pertussis cases are asked to exclude from work, school, other childcare facilities for 5 days after the start of their antibiotics. If they aren't taking antibiotics, unfortunately, it's 21 days from the onset of cough. And we did at Fargo Cass Public Health release last week a pretty detailed news release that covers a lot of this and a lot further information if you're interested. I wanted to also highlight that we did have a hepatitis A case in our north in Grand Forks, North Dakota. It's a little unusual, not something we see all the time. This involved a food worker at a Chick-fil-A at the UND Memorial Union. It is thought that this person contracted this from out-of-state travel, but it potentially exposed many people in the community, and it was recommended that they receive their hepatitis A vaccine or, again, be seen if they were having symptoms. And there was just a really impressive response from local public health. In Grand Forks, they hosted a free vaccination clinic where they were able to distribute and vaccinate numerous members of the community there. At the state level, the Health and Human Services did distribute what we call a health advisory to its health network, just reminding providers to think of hepatitis A if you're seeing patients with those types of symptoms. And then I think because of those efforts, in large part to date, we've seen no additional cases. It was just the one. Little reminder, what is hepatitis A? This is a vaccine preventable infection of the liver. It is caused by the hepatitis A virus. It's considered highly infectious. Typical transmission comes from eating contaminated food and or water, which is why it was such a concern to have a food handler be infected with this. You can also see it with person-to-person contact and other high-risk exposures in the community. Really wide window for symptoms to develop, anywhere from 15 to 50 days. Symptoms can last upwards of 2 months, and they might include things like feeling really tired, being nauseous, abdominal pain, and jaundice, kind of yellowing of the skin and or the eyes. And the best prevention for hepatitis A is a hepatitis A vaccine, especially, as soon as possible if you think you're exposed. We give this as a routine vaccine in childhood, so anyone who's had 2 doses of this vaccine, or if they've had documented proof of the disease, would not need to be vaccinated. And then many are concerned about measles outbreaks that are continuing and increasing in the United States during this time. Since the start of 2024, we've had 45. I actually looked as of yesterday, that number's increased 4 more since I made these slides. We've had 45 cases involving 17 jurisdictions, one of them being our neighboring state of Minnesota. So this has got a lot of people's attention in public health. This is way more than 2 times the number of cases we would anticipate at this point in the year. And I would draw your attention to one concerning outbreak that occurred in an elementary school in the state of Florida. This was highly publicized. I'm sure you saw some of this. It involved at least 8 cases. But the Florida State Health Department chose to not uphold standards of practice that we follow in public health, particularly in 2 ways. The first way that they said that unvaccinated kids who were exposed to measles could continue to attend school. This is pretty unprecedented. Those with no prior immunity need to stay isolated for 21 days. And then second, they failed to recommend that children without immunity get vaccinated. So unvaccinated people can still get protection from a vaccine within 72 hours of exposure. So the standard of care in public health is that if someone is vaccinated within 72 hours, they can actually return to school as long as they don't develop symptoms. But this was not recommended in Florida in this situation. So from a public health standpoint, the purpose of requiring unvaccinated children to isolate after measles exposure is to really halt transmission. So given how contagious the measles virus is, it's actually the most infectious that we know of, and how serious this disease can be for children, failure to enforce such guidelines certainly enhances the likelihood of a prolonged outbreak, as well as potentially endangers lives. And just a reminder, as we see this play out in numerous states in the country, our MMR rates here in North Dakota, MMR is the measles vaccine. This is looking at school-age kids in North Dakota, is just far below the herd immunity level that we would need to prevent an outbreak, that level being 95%. So this data is actually from last school year, and you can see our kindergarten MMR rate was 91%. Preliminary data that I've seen from this current school year, it's not published yet, is actually worsening trends, both for our vaccine coverage and our exemption rates. And then in our younger kids in North Dakota, the numbers are even lower. So this is showing statewide MMR coverage for 19 to 35-month-olds as of the end of last year, 2023. And you can see we're at about 80%. I pulled just Cass County, and we are only at about 82% for this age group, putting us at very high risk if we were to see a measles case. And then shifting gears a little bit, CDC is reporting nationwide that flu cases are remaining elevated, while RSV and COVID-19 infections are trending downward. I would say that's holding true here in North Dakota as well. Here you can see the percentage of outpatient visits for what we call influenza-like illness. This is a weekly national summary that's put out by the CDC, and it compares this season, the 2023-2024, that's shown in the red line, to the 5 previous influenza seasons. So you can kind of appreciate we've been holding steady for the past few weeks, but still at quite an elevated level. This past week in the United States, 12 jurisdictions experienced moderate influenza activity and 27 experienced high or very high influenza activity. You can appreciate North Dakota in the red there remains in high activity level. Also of note, we're continuing to see influenza deaths. Unfortunately, to date, we have had 93 pediatric deaths this season. But meanwhile, COVID-19 hospitalizations and deaths, which are kind of used as severity markers by the CDC, both declined last week. However, hospitalizations did remain elevated for the very old and the very young. And then early indicators like the nation's test positivity rate trended down while our wastewater detections remained high. And nationwide, the RSV situation continues to improve with levels declining in many regions. RSV hospitalizations decreased both for infants and older adults, and our RSD deaths are remaining stable. So it does appear that we have hit our peak for seasonal RSV, which is a relief. That was nationwide data. This is the North Dakota Flu Weekly Report put out by our state. You can kind of see that flu activity remains elevated and several metrics actually increased from the previous week. Flu hospitalizations and deaths are continuing statewide in keeping with that US trend data that we saw. Influenza-like illnesses remains really above seasonal baseline. The majority of cases previous to this week had been influenza A. Flu B typically spikes toward the end of flu season, and that's now what we're seeing make up the majority of our newly diagnosed cases here in North Dakota. So a reminder, we can all do our part to reduce respiratory diseases this fall by staying up to date on vaccines, washing our hands often, covering our coughs and sneezes, and staying home when we are sick. So unfortunately, national vaccination coverage for COVID-19, flu, and RSV remains low for all children and adults. This holds true for North Dakota as well. I would say there's still time to get vaccinated, as many people are missing out on this layer of protection. But I thought I'd end with a little good news. There was new data out that 40% of infants in the United States got protection from Nursivimab. That's that new immunization I presented to you guys about RSV. This data was a little surprising given the supply and access issues that we had with Nursivimab. But there was some CDC survey data shown here that as of January 24th, among females that had an infant under the age of 8 months, over 40% reported that their infant received Nursivimab. And then an additional 21.7% reported that they definitely plan to get Nursivimab for their infant. Among females that were pregnant in January, 38.2% reported that they definitely plan to get Nursivimab for their infant. And then among females who are trying to get pregnant, 44.4% reported they definitely plan to get Nursivimab. So we were pleased to see these numbers. And there was actually data just released yesterday or published yesterday that Nursivimab was 90% effective in preventing hospitalizations in children this season. This was really important first real world data or evidence of its effectiveness. And then a final slide that ACIP, which is the advisory committee to the CDC, met at the end of February for their regular meeting to review vaccine recommendations. And they recommended that people 65 and older should get a COVID booster this spring. This is similar recommendations that are out from Canada and United Kingdom and other places. They presented a lot of data. I selected one point here. This is a piece of data showing that people that by and large that are hospitalized for COVID-19 still are just not up to date on vaccines. So the vast majority of people coming into the hospital in the United States have not had either that monovalent or bivalent booster. And that of course includes those over 65. They also presented data to show that the fall vaccine COVID vaccines had pretty decent efficacy. They were comparable to our seasonal flu vaccines, and that for the most part, they were cost effective for this population. With that, I'm happy to entertain any questions.
Any questions for Dr. Newman?
Information overload.
It was good information though. Yeah. And reminder to people that get their Tdaps boosted.
Yes, please. Thank you so much.
Okay, thank you. I just need confirmation. I don't see anyone signed up for public comment. Okay, so the record can reflect that there were no public comments. Wanted to echo Dr. Newman's recognition of International Women's Day. Proud to be among my female peer group. Any other business to discuss before we adjourn? Okay. No further business, so we will adjourn the meeting at 1:24, and our next meeting is scheduled for May 10th.